Okay, so first thing about the respiratory system would be function, and the main function is going to be the exchange of gases. So the respiratory system is going to exchange gases between lungs and circulation, and it's going to provide oxygen to the blood and remove CO2 from the blood. So that is main function of the respiratory system. And so there is a connection between respiratory system and circulatory systems. They complement each other for their functions. Now, respiration, this part is important, where what we call breathing is ventilation. That is the mechanical bringing gases in and out of the lungs. So breathing in and breathing out, that's ventilation, okay? Now, what we call respiration in physiology refers to exchange of gases. So respiration is going to be the exchange of gases. And external respiration will be the exchange of gases between the lungs and the circulatory system, and blood. So oxygen will be given to blood, and CO2 will be given to the lungs by the blood. So that's what we mean by external respiration. Then the gases are going to be transported by the blood, and internal respiration is another exchange of gases, in this case between circulatory system and tissues. And in this case, the circulatory system is going to give up oxygen to tissues and pick up CO2. So definitely know the difference between internal respiration and external respiration. That is an important concept. And we'll go back to both later on. As far as the anatomy of the respiratory system, we divide it into two parts: the conducting system and the actual internal respiration part. So the conducting zone and the respiratory zone. Those will be the two parts of the anatomical structures of the respiratory system. The conducting zone are the structures that are involved in ventilation. So conducting zone is involved in ventilation. So conducting zone. So bringing the gases in and out of the lungs. Versus the respiratory zone, which is involved in external respiration. So you should be able to name the organs of the conducting zone from the nasal cavity all the way to the end of the conducting zone. Okay, and we'll go ahead and go through that. So air first enters the nasal cavity. From there, it travels to the nasopharynx. From there into the oropharynx and the laryngopharynx. And you should definitely know those three parts of the pharynx. From there, it goes into the air pipes, which will be the first one will be the larynx, which is the voice box. From there into the trachea, and at the trachea is going to divide, the trachea divides into two tubes, which are the primary bronchi, one on the left, one on the right. Primary bronchi will subdivide in the lungs, into secondary bronchi, tertiary bronchi, and then successive smaller and smaller conduits until we get to the bronchioles. And then the last of the bronchioles is the terminal bronchiole. So we'll go ahead and go over the conducting zone structures here again in just a second. Respiratory zone, on the other hand, are the anatomical structures that are involved in external respiration. So that will be the exchange of gases between lungs and respiratory and circulation. This conducting zone is involved in ventilation. Respiratory muscles are the muscles that, again, are involved in ventilation. They're the ones that are going to make ventilation possible. And we'll talk about those muscles here in just a second also. Okay, one of the things to note about some of these organs of the conducting zone, especially the ones at the very beginning, is that some of their functions is going to be to moisten the air, warm the air, and filter the air. So the function of the nasal cavity, of the conch inside the nasal cavity are going to be these three functions right here. So air must be moistened, warmed, and filtered. I'm not going to go through the parts of the nose. Again, do know the parts of the pharynx. So here you have the nasal cavity, you can see the conch, and the purpose of these ridges is to slow down the air so as to have time to warm it, humidify it, and filter it. From there, air travels into the nasopharynx, oropharynx, laryngopharynx, and from there into the larynx. Okay, again, I'm not going to spend much time on anatomy. Do know, though, the tissues. And pseudostratified ciliated columnar epithelium is the tissue of most of conducting zone. Not all, but most. So when we talk about the nasal cavity, the nasopharynx, those two places are going to have pseudostratified ciliated columnar epithelium. Okay, that's the nasal conch, and again, know the function of these structures. Sinuses are these cavities within bones, and their function is to lighten the skull, to be a resonant chamber for sound. Do know the bones that have sinuses. So the frontal bones has sinuses. Those are the frontal sinuses, the maxillary sinuses, the sphenoidal sinuses, and the ethmoidal sinuses. So know the bones that have sinuses. Okay, so again, know the portions of the pharynx, oropharynx, the okay, let me go back to the oropharynx in just a second. Do know what the pharyngeal tonsils are? I don't know, it's also part of the lymphatic system chapter. The function of the uvula, which is to close the nasopharynx when we eat food, so that food is not going to go into the nasopharynx. So this will be the uvula, which is going to close so that food and drinks do not go into the nasal cavity. Yeah, pharyngotympanic or auditory tube or eustachian tube. Again, that's found in the nasopharynx. So don't forget about that one either. We looked at that one on special senses chapter. Okay, now we said that nasal cavity and nasopharynx were lined with pseudostratified ciliated columnar epithelium, and the cilia of this tissue is involved in cleaning the air, filtering it. Once we go into the oropharynx, however, the tissue changes into stratified squamous epithelial tissue because this is an area where food is going to travel also, so that area is subject to mechanical abrasion. Notice the palatine tonsils in the oropharynx and the lingual tonsils. So know the location of the tonsils. Also know what the epiglottis is. Which made of elastic cartilage and prevents the passage of food into the windpipe. Okay, so the larynx is made of cartilage. Know the cartilages of the larynx. At the front, the main one is the thyroid cartilage, which is huge. Below it, there's a ring of cartilage called the cricoid. And then posteriorly, we're going to see the arytenoid and corniculates. Cuneiforms are hidden in ligaments, so they're not easily seen. Epiglottis is yet another cartilage, but this one is going to be elastic cartilage, which closes when we swallow. So especially for lab, know the location of these cartilages. There's the epiglottis. This is an anterior view, so we don't see the other cartilages. This is a side view. So from here, you can see the arytenoid and the corniculate on top of the arytenoid. The cuneiform is really not easily seen. Okay. The glottis is the opening into the epiglottis, into the larynx, and so the epiglottis is going to close that opening. It's going to close the glottis. True and false vocal cords again help to close the larynx. So these white ones here are the true vocal cords, and the two broad ones on either side are the false vocal cords. I have some idea what the Valsalva's maneuver is. I'm not going to go into it too much, just review it. Okay, so from the larynx, we move to the trachea. And the larynx, as far as tissue, is a mixture of stratified squamous epithelial tissue, and then about 2/3 of the larynx is going to go back to the tissue of the respiratory tract, which is ciliated, pseudostratified ciliated columnar epithelium. And this is the same tissue that we find from that point on forward, for the most part. We'll qualify in just a second. So the trachea has pseudostratified ciliated columnar epithelium. Trachea is made of rings, C-shaped rings, so I guess it will be complete rings, of cartilage, hyaline cartilage. They're lining right there. You can see the little cilia. And it is a C-shaped cartilage. The two ends are being brought together by a muscle called the trachealis muscle, which is a smooth muscle, and the muscle is positioned against the esophagus, which is a muscular tube where food is going to go. And so here's a microscopic view of the tissue of the trachea. There's the hyaline cartilage right here. And this is just some connective tissue with glands. And up here is the pseudostratified ciliated columnar epithelium. Oh, yeah, and I forgot to mention that last cartilage of the trachea is called carina. And you should know that, especially for lab. Yeah, it's a little hard to see, but all the cartilage are C-shaped, and the last one ends up being a little bit thicker and is more of a kind of a triangular shape, and that's the one that's going to split into the two bronchi, the two primary bronchi. All right, so moving on with the conducting zone, we're now at the bronchial divisions, and this will be 23 orders of branching. This is called the respiratory tree. So you can see here the last part of the trachea, and then the two divisions, the primary bronchi on the right-hand side over here, and on the left-hand side over there. And you can see how the left side is longer than the right side. The primary bronchi is going to subdivide as it enters the lungs into secondary or lower bronchi. And there will be 3 of those on the right side, 2 of those on the left side. So let me go ahead and get a better picture here. So from the trachea, we're going to divide into primary bronchi. From the bronchi, we're going to divide into secondary bronchi. Yeah, the right main bronchus, the primary bronchi, is wider and shorter and more vertical than the left. Each bronchus supplies 1 lobe. Now we go into the secondary. Okay, I don't know what the secondary is, but secondary bronchi is also called lower bronchi. So each lobar bronchus branches into segmental or tertiary bronchi. Let me go back here to the picture. All right, here you can see the carina. Here is the left primary bronchi. This is the right primary bronchi. The left primary bronchi subdivides into two secondary or lobar bronchi. There we go. There's going to be two of those on the right-hand side. They're called lobar because they're going to go into the lobes of the lungs, and there are two lobes on the left lung. There are three lobes on the right lung. So this one is 2 and 3. So those will be the three secondary bronchi or lobar bronchi on the left-hand side, because the right side has three lobes. So there'll be three secondary bronchi or lobar bronchi. Secondary bronchi are going to divide into segmental bronchi or tertiary bronchi. On both sides, we're going to divide into the tertiary. So secondary divides into tertiary. Okay. And that's when we stop counting, but know that there are 23 levels of division. So there will be progressively smaller and smaller bronchi until these tubes become so tiny, about 1 millimeter in diameter, and then we call them bronchioles. Now, bronchioles and bronchi have more than just size differences between them. Bronchi are going to have lots of cartilage and less muscle. As we move from primary bronchi to secondary bronchi to tertiary bronchi, the amount of cartilage to muscle changes. And the smaller the tube, the more muscle, the less cartilage. So we're going to go from large tubes are going to have lots of cartilage, less muscle, and the muscle is a smooth muscle. Small tubes are going to have less cartilage, more muscle, until we get to the bronchioles. And the bronchioles are only smooth muscle. So no cartilage, only smooth muscle for the bronchioles. So at that point, we're talking about muscular little bitty tubes. The smallest of the bronchioles, as they progressively become smaller and smaller from the 1 millimeter larger bronchioles, are less than 0.5 millimeters, and it's called the terminal bronchiole. So the last conduit of the conducting zone is the terminal bronchiole. Okay. Just like the makeup of the tubes change from less cartilage, more muscle, the tissue lining the tubes also changes from the stratified ciliated columnar epithelium to a cuboidal epithelium that is going to have progressively less cilia and goblet cells. Okay. So just want some room here. Okay, so as far as the conducting zone, we went from nasal cavity to nasopharynx to oropharynx to laryngopharynx to larynx, trachea, primary bronchi, secondary bronchi, which are also called lobar, tertiary bronchi, which are called also segmental. And then we stop counting, but there are other conduits until we get to the bronchioles. And the last of the bronchioles is the terminal bronchiole. As we said, the last of the bronchioles of the conductive zone. Remember, the tubes change from having lots of cartilage, less muscle, having a tissue of pseudostratified columnar, with cilia, to the very smallest of tubes like the bronchioles and the terminal bronchioles, to having no cartilage, only muscle, smooth muscle. The tissue is cuboidal with very little cilia, so hardly any cilia left. Now remember that pseudostratified columnar epithelium with the cilia is protected because of the cilia, because of the mucus it secretes. So as the tissue becomes progressively, the cells become progressively smaller, and with less cilia, they're less protected. So the further we go into the conducting zone, the less protection there is from invaders, etc. Anyway, so you should know the parts of the conducting zone. So remember, the last of the conducting zone conduits is the respiratory bronchiole. Picture here. Sorry, the terminal bronchiole, not the respiratory bronchiole. All right, so here's the respiratory bronchiole, which is the last structure of conducting zone. The terminal bronchiole is now we're going to go into the respiratory zone. The terminal bronchiole is going to divide into respiratory bronchioles, which lead into the alveolar ducts, which leads into the individual alveoli, which make up alveolar sacs. And that's it for the respiratory zone. So respiratory zone is made, go back to the picture here. There we go. It starts at the respiratory bronchioles, which are going to lead to the alveolar duct, which in turn, so this is the alveolar duct, which in turn lead to the individual alveoli, which collectively make up the alveolar sacs. The tissue of the respiratory zone is simple squamous epithelial tissue. So it's this thinnest of tissues. Okay, so make sure I didn't leave anything out. Yeah, just note how many alveoli we have. We have 3 million alveoli, little alveoli sacs. This picture right here, this is the pleura. So this will be the visceral pleura. The little pink area is the cavity, the space, and then this will be the parietal pleura. So notice that the visceral pleura goes inward and creates these little segments inside the lungs. Okay, so alveola itself is made of 3 types of cells, actually. Immune system cells, phagocytes, but also most of the cells are going to be type 1 cells, which are the simple squamous epithelial tissue we just talked about. A few of the cells are going to be type 2 cells, which are actually cuboidal instead of squamous cells. And these are cells that secrete a product called surfactant. So there's a picture of of the respiratory zone. This is the terminal bronchiole, the last of the conducting zone, which is branching into respiratory bronchioles, which in turn are going to go into the alveolar duct that lead to the alveolar sacs. Notice the relationship between alveolar sacs and capillary blood vessels. So each one of those sacs is surrounded by a little ball of capillaries. Also notice here they're showing you that each of the alveoli are also made of elastic fibers. So the alveoli should be elastic, should have a recoil about them. Okay, the alveoli are connected to each other, so they're not independent little air sacs. They are connected to each other. So see here how they are connected to each other. These are the little capillary blood vessels that interact with the alveoli. The clear-looking cells are going to be the simple squamous epithelial cells. The green cells are the type 2 cells that secrete surfactant. Definitely know these cells. And then the bluish ones are immune system cells. This right here is the respiratory membrane, which is the membrane that facilitates the exchange of gases. So remember, at this point in this respiratory zone, the exchange of gases corresponds to external respiration, which means oxygen is going to go from lungs to blood, and CO2 is going to go from blood to lungs. Now, these are very small molecules that can diffuse following a concentration gradient. So you see here how oxygen goes through the respiratory membrane and CO2 and reaches the blood, and CO2 leaves the blood and goes into the respiratory membrane. The reason why this can happen is because the respiratory membrane is very, very thin. Diffusion requires a thin membrane. If we don't have a thin membrane, diffusion cannot happen. So this is the little cell, squamous cell, simple squamous epithelial cell. The cells making up the capillaries are simple squamous epithelial cells also. So we have two simple squamous epithelial cells next to each other. You cannot get any thinner than that. Two little flat cells next to each other. So the respiratory membrane is incredibly thin, and that's what permits this exchange of gases. So definitely know what the respiratory membrane is. Simple squamous epithelial cell of the alveoli, a little bit of connective tissue, simple squamous epithelial cell of the capillary. So we'll go back to this principle of this respiratory membrane being thin here in just a second. The lungs themselves, I'm not going to worry too much about them. You should have seen in anatomy. I remember the hilum is the part where all the tubes go in and out. And in the lungs, it can better be seen from behind. Know the difference between left lung and right lung. Know how many segments each has, or first I should say how many lobes each of them has, which one has the cardiac notch. Know the blood vessels that supply the lungs. Right and left pulmonary arteries are going to bring deoxygenated blood from the right side of the heart, right ventricle, to the lungs. Right and left, there's two, right and left pulmonary veins are going to carry oxygenated blood out of the lungs towards the heart, towards the left side of the heart. So you should definitely know blood vessels that irrigate the lungs. Oh, there we go. Let's see, where are they? Okay, there we go. This will be a branch of the pulmonary vein. These are the alveolar capillaries. So this will be a branch of the pulmonary artery. Notice the difference in color. Blue for the pulmonary artery because it's bringing the oxygenated blood. Red for the pulmonary vein because it's taking away back to the heart oxygenated blood. Okay, so we're going to talk about ventilation. How does we breathe in and out? And the relationship between the pleural membrane and the lungs and the thoracic cavity are very, very important in ventilation. So if you look at this picture and you see this membrane right here, which is lining the thoracic cavity, that is the parietal pleura. I should be here somewhere. Yeah, there we go, parietal pleura. The whitish membrane that actually touches the lungs is the visceral pleura. Between these two membranes is a very thin space filled with fluid, the pleural fluid. So you have two very thin membranes and fluid in between, which means the two membranes are going to be stuck to each other because fluid is water and water molecules cling to walls and to each other, effectively kind of sealing that area and bringing together those two membranes. But the visceral pleura is the part of the lungs themselves. So what's going to happen, the reason why this is crucial is because what's going to happen during ventilation is we're going to expand our rib cage. And as we do that, the visceral pleura is also expanding with the rib cage, but the parietal pleura, I should say. The parietal pleura is expanding with the rib cage. The visceral pleura is stuck to the parietal pleura. So as we expand the rib cage, the visceral pleura is also going to expand and increase the volume of the lungs, makes the lungs bigger by doing that. So that's going to be what takes place during inhalation, and air is going to rush in. So it is dependent on this relationship between visceral and parietal pleura. The two membranes must be stuck to each other so that when one pulls outward, the other one has no choice but to follow. So anything that compromises that relationship between the two pleural membranes is going to compromise ventilation. Okay, so we're going to talk about the mechanics of breathing, of ventilation. Inspiration is breathing in, and expiration is breathing out. All right, well, we're basing what the reason why we can breathe in and out is because there is a relationship between pressure and volume. So that if we have a container filled with a gas, and we take the container and we bring that piston upwards, making the container bigger. So effectively, we are increasing volume. What that does is now the area is bigger, and that's going to decrease the pressure. The pressure is due to gas molecules bumping against the walls of the container and bumping against each other. If all of a sudden we make the container bigger, now it's less likely for these air molecules to bump against each other, and so the pressure changes. There's less pressure because there's less bumping because the container has become bigger. So because there is less pressure inside the lungs, but the pressure outside has not changed, so comparatively speaking, now is bigger, it's a higher pressure than inside, the less pressure inside draws air into the lungs, and that would be inspiration. So is this decrease in pressure that is due to an increase in volume that makes air rush into the lungs during inspiration. So the intrapulmonary pressure is going to fluctuate as we breathe in and we breathe out. When we breathe in, the pressure is falling. When we breathe out, the pressure is going to increase. I'll come back to intrapleural pressure here in just a second. I'll come back to the PowerPoints that I'm skipping here in just a second. Yeah, give me a sec. Okay, this is, oh, there we go. This is what I want. All right, so again, the reason why we breathe in is because we're going to expand the thoracic cavity. There are two muscles that allows us to expand the thoracic cavity, and these are going to be called respiratory muscles. The respiratory muscles are going to be, and these are both skeletal muscles, the diaphragm and the external intercostals. So the external intercostals are going to expand the rib cage outward. The diaphragm is going to expand it inferiorly. Okay. So as that happens, the lungs are expanded, the volume of the lungs fall. When the volume of the lung becomes smaller, there is less pressure, and the higher pressure from the atmosphere rushes in. Now, this is the deal though. The difference in pressure between the inside of the lungs and the outside is really not that dramatic, but it's enough to allow air in. Outside, the pressure is 760 millimeters of mercury. Inside, when the rib of the lungs, when the rib cage has expanded, the pressure is going to be 759 millimeters of mercury. So it's 1 millimeter of mercury less. So instead of calling it 759 millimeters of mercury, sometimes it's just called -1 millimeters of mercury. And what they're really saying is 1 millimeter of mercury less than atmospheric pressure. And we'll talk about expiration here in just a second. I'm going to go back to the places that I skip. Okay, now expanding the lungs is going against the natural state of the lungs. The natural state of the lung is to collapse because there are lots of forces in the lungs that are pulling it inward to collapse. The two main forces is elastic recoil. The minute we expand, because there is so much elastic tissue in the alveoli, the minute we expand the lungs, it's like a rubber band that has been stretched and now it's going to want to go back to its original shape. So that elastic recoil is tending to collapse the lungs. The other problem is surface tension. We mentioned that the air that's going in is being humidified. By the time we get to the individual alveoli, air is 100% humidified. So this is the problem. We have these incredibly thin structures, the alveoli, the sacs, which are loaded with water. And the water molecules cling to each other. And they're going to want to stick to each other. So the walls of the alveoli tend to stick to each other and collapse. So there's another force that is collapsing the lungs. Type 2 cells in the alveoli make a substance called surfactant. And surfactant is like a soap that is going to position itself between the water molecules and prevent them from wanting to come together. So surfactant is going to decrease this surface tension that in the alveoli that is wanting to collapse the alveoli. So the two forces that are pulling the lungs to collapse is the elastic recoil and the surface tension. Okay. The surface tension, we take care of it with surfactant. The elastic recoil actually is going to be taken care of with negative pressure from the pleura. Give me just a second. All right, so let's see. Let's talk about that negative pressure. So again, that space within the two pleura is incredibly important. Not only because it allows the lungs to be stretched, but on top of that, it is a negative pressure space that is going to pull on the lungs. So notice here, it's negative minus 756, so it's a negative 4. So it's negative 4 inside in that pleural space. Because it's a negative pressure, is less than the pressure inside the lungs, is going to act like a vacuum and it's going to pull on the lungs and prevent them from collapsing. So when we go back here again, the two forces that are collapsing the lungs is the elastic recoil and the surface tension. Take care of the surface tension with surfactant. It's going to prevent lung collapse. The elastic recoil, we're going to take care of it with negative pressure in the pleura. Okay, so another thing that helps or prevents lung collapse is that the thorax is going to pull outward. The muscles are going to be pulling it outward, especially when we breathe in. So the chest wall elasticity. A negative pressure in the pleura is going to prevent lung collapse also, and then surfactant will be the other factor that is going to prevent lung collapse. So keep this in mind. So when does lungs collapse? Well, the lung is going to collapse if we don't have surfactant. But that really is not a problem once you're an adult. That's a problem of premature babies, for example. But that's not really a problem of adults. What could be a problem of adults is loss of chest wall elasticity, for example. That could happen if you break a rib, for example. Or even worse, if that broken rib punctures the pleura and damages this negative pressure, then the lungs could collapse. So those are the things that could cause lung collapse: a broken rib, a mechanical injury to the pleura. So what's preventing part of what's preventing lung collapse is that intrapleural pressure. A collapsed lung, we will probably have to go into a ventilator to force air in and force the ventilation to continue. And then just wait for it to fix itself. So it will need to be forced. Obviously, if it is a broken rib that has puncture, then you'll kind of have to do something about that, probably some form of surgery. If it is a stab wound, again, surgery to fix it. But if the lung collapse is due to other reasons, like, for example, a broken rib that has not collapsed, that has not punctured the pleura, there will be a matter of helping out with the ventilation with the machine, so the patient can continue breathing until the injury heals enough to where it can do its job. The other thing will be inflammation that will collapse a lung, because inflammation is going to put fluid in the pleura, and that's going to compromise the negative pressure. So again, now you're going to need a respirator until they can deal with the inflammation. So the lung collapses is typically what you need then is a respirator that is going to force air into the lungs. And really, that's what happens to COVID patients. COVID patients, part of the problem is inflammation in the pleura, which is going to compromise breathing because we're going to compromise also, not only in the pleura, but also in the lungs themselves. We're going to compromise the respiratory membrane. It's not going to be thin anymore. Now it's going to be thick. And so you're going to need to, you have two problems. The lungs are going to want to collapse, and then the thickening of the pleura. So that's what you need to, the ventilator to force the breathing. Patients are typically put in a prone position, face down, because that actually helps breathing. So the minute you put the patient face down, it's going to help breathing. So when somebody having problems breathing, the face down position is the best position to help breathe, to help the person breathe. And then forcing the air in, which they have to be careful on, because if they force too much air in, they may overexpand or damage the alveoli. A collapsed lung is called atelectasis. And again, plug bronchial, that would be another thing that could give you a lung, a wound, mechanical wound that admits air into the pleural cavity. That's called pneumothorax. Okay, inflammation will do it too. So, know the role of intrapleural pressure in ventilation, especially inspiration. So we talked about inspiration being the process that we take air in, and what we're doing when we do that is we expand the rib cage with the external intercostals and the diaphragm so that we increase volume, which is going to decrease pressure, and that's going to send air into the lungs because the lungs become a vacuum. And obviously the pleura is helping with that too. So the two muscles involved are the diaphragm and the external intercostals. And you should definitely know that. These are called the respiratory muscles. And to be more precise, these are the muscles of quiet inspiration. So when we're breathing in normally. If you want to force more air into the lungs, now you need to contract extra muscles. The extra muscles of inspiration are the scalenes, pectoralis minor, sternocleidomastoid. And again, do know which ones are the muscles of forced inspiration. Now, quiet expiration is a passive process. It does not need muscles. What it needs is the relaxation of the external intercostal and the diaphragm. That's what causes expiration. Expiration is going to be the opposite event. So what we're going to do now is relax the external intercostal, relax the diaphragm. So now we're going to lower the volume, which is going to increase the pressure, and air is going to rush out because the pressure outside will be less than the pressure inside. The pressure inside becomes 761 millimeters of mercury, which we're just going to call +1. So quiet respiration relaxes the diaphragm and external intercostals. Now, if you want to forcefully breathe out more air, the muscles of forced expiration are going to be abdominal muscles and internal intercostals. And yes, you definitely need to know this. And do know the mechanics. Too much pressure can damage the alveolar. What you're referring to, just again. Yeah, I was referring to the alveolar because it is such a thin membrane. And the blood vessels, yeah, you could definitely also damage the blood vessels, no question. But the alveoli is very, and the capillaries are also very, very thin. So, but mainly the alveoli. What it will get damaged with a respirator, what could get damaged with a respirator, is the alveoli. Yeah, you could overexpand the alveoli, and the part of the problem with overexpanding the alveoli is that once you mess with the elastic tissue, now the elastic tissue is not going to recoil anymore. So you're going to end up with a permanently overexpanded alveoli. So that's something that doctors have to be aware of, and so they're trying to just put enough pressure to and that's another problem also again with these kinds of with COVID, for example, is that you're putting enough pressure to give enough air to keep the patient alive, but the patient feels like it's not getting enough air. So it wants to breathe more, but obviously it can't. So that's part of the problem. You're getting just enough air to not damage the alveoli, but the patient doesn't feel like it's getting enough air. So it has an instinct to want to breathe more or take off the respirator. So they typically have to sedate the patient so that it doesn't go against what the respirator is trying to do. So that adds another complication to the whole picture there. So that's why respirators are difficult to deal with. This picture is showing you inspiration, expiration. So let me get this straight. Yeah, this pink one refers to what's happening in the lungs. So when you breathe in, the pressure goes down, -1. Breathe out, the pressure goes up, +1. So that air goes in, air goes out. This is what's happening in the pleural space, which is always negative. Hovers between -4 and -6. So when you're breathing in, is about -4, goes all the way to -6, which is really pulling and expanding even more the lungs. And then it goes back up to -4 when you're breathing out. And that's just the volume of air breathing in and out. Definitely know how we breathe in, how we breathe out. Increasing volume, decreasing pressure. The muscles are relaxing in expiration. In inspiration, we are decreasing volume, which increases the pressure. The muscles, external intercostals and diaphragm, are contracting. So be aware of the mechanics and expect questions about these mechanics, how it works. Okay, so know the mechanics of breathing in and breathing out. Okay, factors influencing pulmonary ventilation. Okay, we kind of talked about those already. We talked about alveolar surface tension. And again, we fixed that with surfactant. So as long as we have surfactant, that really is not a problem. Airway resistance, okay? So that means the conduits that are taking air into the lungs, into the alveoli, should be in good standing. So anything that's obstructing the conducting pathway will take less air, will compromise ventilation. Okay, lung compliance, that is the ability of the lungs to expand with very little air. So lungs should be like balloons. That's what having good compliance means. It means a little bit of pressure expands them a lot. Okay. So prevent ventilation. Well, go back here. Mess with the airway resistance. That happens, for example, with an asthma attack. So with an asthma attack, all of a sudden the airways become closed. there's a lot of airway resistance, air cannot get in easily, you're going to stop ventilation. Epinephrine, which is a sympathetic nervous system hormone, is going to dilate bronchioles. The sympathetic response is to dilate bronchioles and reduces airway resistance. Surfactant takes care of alveolar surface tension, right here, number 2. Okay. Again, surfactant is typically not a problem, or cells produce surfactant unless you're dealing with a premature infant. Premature infant, their type 2 cells are not producing surfactant, and so they are born oftentimes with respiratory distress syndrome. And again, they have to be put on respirators. Lung compliance, which is the ability of the lungs to expand. Surfactant, obviously keeps lung compliance. Other things that can mess with lung compliance, fibrosis of the lungs, scar tissue in the lungs, which now that is scar tissue compromises the elastic tissue. So now there isn't as much elastic tissue. Again, reduced surfactant, decreased flexibility of the thoracic cage, which that could happen with a broken rib, for example. Other factors that could affect lung compliance are deformities of the thoracic cavity that could be due to a scoliosis, kyphosis, or an abnormal curvature of the spine, especially if there's a pronounced abnormal curvature of the spine, would definitely compromise compliance. Ossification of the costal cartilage. This is something that happens with age. So as we age, the ribs are less flexible because there is more bone, less cartilage. So an 80-year-old lung compliance will be less than a 30-year-old lung compliance because an 80-year-old will have less cartilage in the ribs than a 30-year-old. Paralysis of intercostal muscles. Okay, that is explains itself. All right, so know the factors that can affect lung compliance. Definitely know the effect of surfactant and the cells that produce surfactant. Okay, this is not too bad. This is it for first set of PowerPoints. Any questions? All right, so I'm going to do the same with the second set, which is shorter set, it's a smaller set. I'm going to go a little quicker. And the second set deals a little bit more with physiology. Okay. A second. All right. Okay, so you need to know the names that we use to describe the volumes in and out of the lungs, and we'll talk more about those in just a second. Let me go for the picture. I'll go over this in just a second. I want to go for this right here. Okay, right there. All right, so definitely know this picture. Expect a curve like this in the test and be able to determine what each of these curves mean. First of all, this one right here in the middle, that's the tidal volume. This is, if you will, normal ventilation, also called quiet ventilation. So as you're breathing in and out without making much effort, that's the tidal volume. And the tidal volume brings in and out about 500 mils of air. The muscles responsible for this tidal volume are going to be the diaphragm and the external intercostals. So these are the muscles of respiration. Okay. Now, if we use extra muscles when we're breathing in, like the scalenes, the sternocleidomastoid, the pectoralis minor, now we could breathe in more air than the tidal volume, right there. This is called the inspiratory reserve volume, inspiratory reserve volume, IRV, right there. We get the inspiratory reserve volume by using the extra muscles of inspiration. And you should know those are sternocleidomastoid, pectoralis minor, scalenes. Okay, I meant to put inspiration. Okay, that doesn't help. Extra muscles. Okay, I'm just going to leave it as extra muscles. Okay, and know which are those extra muscles. By the same token, if we breathe out using extra muscles, now we can breathe out a bigger volume of air, and that is what we call the expiratory reserve volume. Muscles used at that point would be abdominal muscles and internal intercostals. Okay? There is a volume of air trapped in the lungs that we'll never get rid of unless the lungs collapse, and that's the residual volume. So know the volumes and know in the chart what part represents which of the volumes. So these are the volumes. The capacities are more than one volume added up. And out of the capacities, one of the most important capacities is vital capacity, because vital capacity refers to the maximum volume of air that can be moved in and out of the lung. So the maximum volume of air when you're using every single possible muscle that you can use to breathe in and breathe out. So vital capacity is the tidal volume plus the inspiratory reserve volume plus the expiratory reserve volume. So all the volumes except residual volume. Total lung capacity is all the volumes including residual volume. Inspiratory capacity is the maximum volume of air that you can breathe in, and that would be the tidal plus inspiratory reserve volume. And then functional residual capacity is the volume of air that you can breathe out plus the residual volume. Okay, so know what is a capacity, know the volumes. Okay, and the PowerPoints that I skipped over are the ones talking about these concepts. There's your capacity, so there's TLC, vital capacity, inspiratory capacity, functional residual capacity. Now, as far as the air that's breathed in, not all of it is going to make it to the alveoli. Some of it is going to be trapped in the conduits. So that is a constant volume that is always lost from the air that we breathe in. And it's about 150 milliliters of air. That every time we take a breath in, those 150 mils are never going to make it to the alveoli. Alveolar dead space, that one changes because that one reflects the alveoli that are non-functional at any given time. So we don't know what number that be, change depending on the conditions of the patient. However, this one doesn't change. So that one is a constant. The total dead space will be the anatomical plus the alveolar. So pulmonary ventilation is the volume of air breathed in every minute. The volume of air breathed in at each breath times the respiratory rate gives us the volume of air breathed in every minute. So you multiply the volume of air every breath times how many breaths per minute, and that gives us your breaths they cancel each other, and then we get mils per minute. So that's the volume of air per minute. Now, however, this does not take into account the dead space. Remember that out of those 500 mils, the total dead space, which is at least 150 mils, are going to take that away from the total air breathed in. So out of the 500 mils, you take away 150 that's trapped in the conduits, and you're only breathing in 350 mils per breath, giving you 4,200 mils per minute. So that's the actual volume of air that will be used to exchange. Now, the other principle behind these is if these pulmonary ventilation depends on how much air you breathe in every minute, and that depends on how many breaths you take in, what would it be better? To take many small breaths per minute or fewer but deeper breaths per minute? Now, instinctively, if I were to ask that question, most students will answer, well, deeper and fewer breaths are better. And that is correct. The question is, why? The reason why is because of the dead space. Every time you breathe, you have to pay the tax. The tax is 150 mils per breath. So if you breathe 600 mils per breath, and you have to pay 150 mils every time you breathe, you end up only getting 450 mils per breath. Okay, but if you breathe these 400 mils per breath instead of 600, so this will be the deeper breath, you're going to pay the tax of 150 mils per breath. Now you're bringing in 250 mils per breath. You can breathe 15 breaths per minute, but you're only bringing 250. Whereas you can reduce the breathing rate to 10 breaths per minute, and if the breaths are deeper, then you're bringing in more air, then you're bringing in 4,500 mils per minute versus 3,750 mils per minute. Okay, so the answer to the question as to why is it better to breathe fewer breaths but deeper breaths, so more air in fewer times, is because every time you breathe, you're going to have to pay that 150 mils tax to it. Okay, so it's better to have one big breath and take 150 mils out of that than to have many small breaths and every one pays 150 mils. Okay, hopefully that makes sense. You should be able to explain that. All right, pulmonary function tests are the tests that measure the functioning of the lungs, and that the test will be things like forced vital capacity, which what you can measure is the air breathed out. So forced vital capacity is the volume of air that can be forcibly expelled out during 6 seconds of expiration. And that means forcibly, that means every single muscle you can possibly use to breathe out, you're using. So that would be, the abdominal muscles and the internal intercostals. Forced expiratory volume 1 measures the amount of air breathed out in the first second of forced expiration. The first second is when we breathe out most of the air. So what this is measuring is the conduits and how well the conduits are allowing us to breathe out. So pulmonary function tests can put a patient into one of three categories. The patient may have normal lung function, or it could have an obstructive pulmonary disease or a restricted pulmonary disease. And best way I found to explain the difference between obstructive and restrictive, I saw it once on YouTube. You imagine a glass of water and with a straw. And in an obstructive disease, there's nothing wrong with the glass of water. There is something wrong with the straw. So the straw may be very thin, which is not going to allow for much water out. air out. So notice that there is a normal TLC because there's nothing wrong with the glass of water. Sometimes the TLC may be actually increased a little bit because maybe the glass of water has expanded a little bit because the glass of water is the lungs, the elasticity of the lungs may be a little bit stretched. But typically it's just a normal TLC because there's nothing wrong with the lungs. There is something wrong with the straw, with the conduits. So obstructive diseases will be things like bronchitis, asthma, COPD, chronic obstructive pulmonary disease. Those are the obstructive diseases. In a restrictive disorder, now there's something wrong with the glass of water. So now there's something wrong with the lungs themselves, not with the straw. So because there's now something wrong with the lungs, we're going to have a reduction in the TLC, the total lung capacity. The function test, pulmonary function test may be normal or elevated because there is nothing wrong with the conduits, but there is something wrong with the lungs themselves. So TLC will be reduced. Fibrosis of the lungs, for example, could be is a restrictive disorder. Tuberculosis is a restrictive disorder. So you should be able to distinguish between restrictive and obstructive pulmonary disease. So obstructive is the easy one, decreased airflow due to some type of problem with the conduits. And again, asthma, COPDs, bronchitis, emphysema, cystic fibrosis are all obstructive diseases. Restrictive, the patient has a decreased TLC. Now there is something wrong with the lungs themselves. Maybe fibrosis of the lungs, an infection in the lungs. It could be a neuromuscular problem also, for example. A problem with the thoracic cage, so the lungs cannot expand as much. All right. Any questions? Okay. We talked about gas exchange, internal respiration, external respiration. Let's see. We talked about, so again, just make sure you understand the difference between external and internal respiration. I'm not going to spend too much time on these. I'm only going to go for what is important. All right, let's see. This is the mixture of gases in the atmosphere. This is what we're breathing in. So what we're breathing in is a mixture of gases in which most of the gases we're breathing in is actually nitrogen. 78.6% is nitrogen, 20% is oxygen, and CO2 and water vapor is minimal. So that's the atmospheric air. Contrast that with the air in the lungs, in the alveoli, which is extremely different. In the alveoli, yeah, we have mostly nitrogen. That doesn't change. We have less percentage of oxygen than we had in the air, but more importantly, CO2 is 5 times more than out in the air. So the alveoli is going to retain CO2. And obviously there's more water too in the lungs than there is in the air. So the biggest difference is going to be right here, CO2. Lots more CO2 and obviously less oxygen, but okay. More CO2 than we have out in the air. So CO2 is actually a very important gas when it comes to exchange of gases, respiration, and ventilation. CO2 is a lot more soluble in water than oxygen. Nitrogen is very little soluble in water, and that's why it doesn't go into the blood. Okay. Alveoli contain more CO2 and water vapor than atmospheric air, and that is due to the mixing of the gases that occurs at each breath. and we'll explain that. Okay, so this is with CO2. The deal with CO2 is that blood cannot get rid of all of the CO2. Blood needs CO2. The reason why blood needs CO2 is because CO2 is involved in regulating pH. And so blood needs the CO2. CO2 is a buffer. You could think of it that way. It's not really, but you could kind of think of it that way. Or it creates the buffer that regulates pH. Okay. So at any given time, blood has to retain CO2. Now, it cannot retain too much CO2. It has to retain the appropriate amount of CO2, not too much, not too little. And that's the reason why CO2 is always retained in the alveoli, is so that it can control how much CO2 is removed from the blood, so that it doesn't remove too much CO2 from the blood. Okay, so these are the lungs, this is the alveoli. So you can see blood coming in, the oxygenated blood coming in from the pulmonary arteries on the right side of the right ventricles. That blood coming in has, there we go, right here, has 40 millimeters of mercury of oxygen and 45 millimeters of mercury of CO2. Okay, the alveoli, as this blood arrives at the alveoli, is going to encounter 104 millimeters of mercury of oxygen, 40 millimeters of mercury of oxygen. Now, the gas exchange is going to be due to diffusion, and diffusion proceeds with a concentration gradient. So for oxygen, we're moving from the alveoli, which has 104 millimeters of mercury. Blood coming in, I'm going to put it blue because it's deoxygenated blood, has 40 millimeters of mercury. The difference between 140 and 104 and 40 is huge. So lots of oxygen is going to jump into the blood because of the steep concentration difference between oxygen in the alveoli, oxygen in the blood. Okay? And that's exactly what we want. So that by the time blood has left the lungs, it has 100 millimeters of mercury of oxygen. So it's completely oxygenated. Okay? CO2. Let's go for CO2. All right, CO2 in the lungs is 40 millimeters of mercury. CO2 in the blood that's coming in is 45 millimeters of mercury. Now, keep in mind, what we need to do is get rid of the CO2. However, the difference in concentration is not very steep. So not much CO2 is going to leave the blood and go into the alveoli to be breathed out. So that by the time blood leaves the lungs, it is going to have 40 millimeters of mercury of CO2. So it's lost only 5 millimeters of mercury to the lungs. The lungs are not going to get rid of all the CO2 in the alveoli. Blood retains most of its CO2 because, again, CO2 is a buffer. It's going to be used as a buffer. So the blood cannot get rid of all of it. It does have to get rid of some of it, but not all of it. Okay? So now we are in the oxygenated blood going out of the aorta, and it's going to go to the tissues. And at the tissue level, the blood that arrives at the tissue has 100 millimeters of mercury of oxygen, 40 millimeters of mercury of CO2. At the tissue level, the tissue has 40 or less millimeters of mercury of oxygen, so 100 to 40 oxygen is going to leave the blood and go into the tissue. The difference between CO2 in tissue versus blood is 45 versus 40. Again, not much different. So only a little bit of the CO2 is going to leave the tissue and go into the blood. Again, CO2 is a buffer. So everybody wants to keep some of it so that it can buffer pH. So do understand what's happening. Does wearing a respirator mask? Yeah, that's a good question. That is controversial. I don't know the definitive answer to that question, but it is definitely one of the caveats. Does wearing a respirator mask like an N95 increases blood CO2 or alveoli CO2 concentration? Any measurement amount? Remember, that was the common claim among people who didn't want to wear masks. Yeah, and that is probably happening. So yeah, absolutely. I need to research the studies. Obviously, is not enough to make anybody sick, but you're essentially breathing CO2. You're breathing more CO2. So you are keeping more CO2 in the blood. So that is probably happening. Now, keeping more CO2 is not as bad as having less CO2. Having less CO2 is more of a problem. Again, think about it. CO2 is a buffer, and you can think of it as a buffer. And our main problem is acidity. So yes, it's going to impact pH. It would be, absolutely. Yes, it is easy to measure. That's why it should be easy to find studies. And I don't know if they've done, I'm sure they've done them. I will be shocked if there is no some difference. I mean, you're breathing back your CO2. So yeah, there's probably a difference. Not enough to stop you from functioning, but that is definitely something that is probably happening. I don't know what, especially, and I would say, I mean, I don't know that the N95, how well it ventilates, but that is one of the caveats. Yeah, definitely. And I'll see if I can find anything more definitive. My assumption was it can't be that bad, otherwise we would have obvious problems. Now, what if the person already has, a respiratory problem and is wearing a mask? Yeah, that would be a different story. Most of us don't. So, I don't know. Let me look into it. Let me look at what is out there. I was just going by. Okay, if it's bad enough, we'll hear about it. But I don't know what are the actual numbers. Yeah. So yes, definitely. Let's see. There's membrane exchange of O2 and CO2 across the membrane. Okay. All right. Okay, let's go for this. Actually, this is not too bad. Okay, what this is saying, this is looking at how fast oxygen goes into the blood, and it's actually very, very fast. This represents the time that a blood cell travels through the alveoli. So from the start of the capillary to the end of the capillary, about 0.75 seconds. Okay, and notice here is the blood is deoxygenated, and within a matter of 0.25 seconds, a little after 0.25 seconds, is completely oxygenated. So within a quarter of the time, or a third of the time, I should say, that it spends in the alveoli, it has already been completely saturated with oxygen. The reason why this happens is because the minute one oxygen molecule jumps into a hemoglobin, remember, a hemoglobin can hold 4 oxygen molecules. So it's like a little car that can have 4 passengers. The minute one passenger opens the door and jumps in, the other 3 rush in. So the attachment of one oxygen into the hemoglobin changes the conformation of hemoglobin, and it becomes more likely, more receptive to the other 3. And that's why saturation of the hemoglobin happens so quickly as soon as the red blood cells begin to travel through the alveoli. Okay, so that's oxygen loading. It happens very, very quickly because of the properties of hemoglobin. Okay. Yeah. Just gonna. All right. We'll already explain these. Ventilation perfusion for external respiration. Okay, this is actually, this makes sense. What this is saying is for ventilation to take place, in other words, for external respiration to take place, ventilation and perfusion have to occur, meaning air has to come in, blood has to be brought in. If one of those two is not happening, we cannot have external respiration. So if ventilation is compromised, doesn't matter how much blood reaches the lungs, you're not going to oxygenate the blood. If ventilation is happening, but blood is not getting into the lungs, then you're not going to get oxygen into the lungs. Okay, so that's kind of, well, yeah, of course, that makes sense. All right, so the way this is going to work is perfusion, circulation of blood, is going to be diverted towards those alveoli that have more oxygen and away from the alveoli that has less oxygen. And again, that should make sense. Why waste time going to an alveoli that has no oxygen if there's nothing to pick up? So essentially, let's see if I can make sense of these. Okay, so if an alveoli has high CO2, low oxygen, that's going to cause the capillary filters in the alveolar capillaries to constrict so that less blood will go to that alveoli. So now we have low ventilation, low perfusion. Well, yeah, because we don't have anything to exchange. On the other hand, an alveola that has lots of oxygen and little CO2 is going to relax its sphincters, more blood goes to that alveoli so that it can give up its oxygen and pick up more CO2. So ventilation and perfusion can take place. That has to make sense, okay? So low levels of oxygen and high levels of CO2 are going to prevent perfusion. Again, that should make sense. On the other hand, the alveoli that has high CO2, the bronchioles are going to dilate so as to get rid of the CO2. So in this condition here, where there's high CO2, low oxygen, the capillaries constrict, so they don't waste their time going to that alveoli, and the bronchioles dilate so as to try to get rid of that excess of CO2. And again, that should make sense. If an alveola has low CO2, the bronchioles constrict so as to keep the CO2. External respiration is also dependent on the thickness of the respiratory membrane. The respiratory membrane has to be kept at 0.5 to 1 micrometer thick so that diffusion can happen. We have a huge surface area, about 40 times that of one's skin. So there's the alveoli, we have tons of little alveoli. That gives us a tremendous surface area for external respiration. Internal respiration, we talked about how that happened already right here, so you have an idea of how that happens. Okay, transport of oxygen is very easy. Oxygen is transported in the hemoglobin. That's basically it. That's just each hemoglobin can transport 4 oxygen molecules, so that a hemoglobin molecule that it's completely saturated is called oxyhemoglobin. A hemoglobin molecule that has lost its oxygen is called reduced hemoglobin. Oxygen has a high affinity for hemoglobin, and the more oxygen, once one oxygen molecule binds to hemoglobin, the other ones are going to bind very quickly. By the same token, once you get into the tissues, when one oxygen molecule opens the door and leaves, the other three rush out. So when one oxygen molecule leaves the hemoglobin changes its shape and kicks out the other three. What we call saturated hemoglobin, it's a hemoglobin that has all the oxygen that it can carry. All right, so the question is, let's see if I can find place what I can write. How the system is going to know, quote unquote, when to give more oxygen and when to give less oxygen. A tissue that is active will need more oxygen. A tissue that is less active will need less oxygen. So how does hemoglobin know to unload more oxygen into an active tissue and less oxygen into a less active tissue? Okay, that is actually easy. I'm just trying to look for places to write, but all right, here, I'll just come back here. All right, active tissue. And when I'm saying active tissue, think skeletal muscle. That you're running a marathon or something, you're in some type of physical activity, that skeletal muscle is active tissue. So that's what we're talking about, active versus not active tissue. Okay, so characteristics of tissue, it's going to have a higher temperature. It's going to have low oxygen, the tissue, because the minute it is given oxygen, it consumes it. So there's low oxygen. There's lots of waste, metabolic waste. There's a low pH because of the high metabolism. Oops, that means, yeah, low pH. And remember that a low pH means lots of hydrogen ions. Okay, so those are the characteristics of active tissue. On the other hand, not active tissue are going to have a lower temperature, more oxygen because it's not being consumed, less waste, higher pH, which means low hydrogen ions. Okay. Under conditions of high temperature, low oxygen, high CO2, low pH, hemoglobin changes its shape and gives up more oxygen. Loses oxygen. Under conditions of lower temperature, high oxygen, low CO2, high pH, hemoglobin retains the oxygen. So that's how hemoglobin, quote unquote, knows how much oxygen to give up. It has to do with what the environment of the tissue is doing to the hemoglobin as the capillaries, as the hemoglobin travels through that tissue. Okay, so definitely know these. What is active tissue? What is not active tissue? What are the conditions under which hemoglobin gives up its oxygen? Okay, so this right here is what's called a saturation curve for hemoglobin. And what it is it's giving you the concentration of hemoglobin in millimeters of oxygen in millimeters of mercury on the x-axis. On the y-axis is giving you the percentage of saturation of the hemoglobin. So if it says 100%, that means 100% saturated, it has as much oxygen as it can hold. If the hemoglobin has a saturation of 20%, that means that it has 20% oxygen, it has lost 80% of its oxygen. 40% saturation means it has lost or given up, I should say, 60% of the oxygen. Get the picture. 60% saturation means it has given up 40% of the oxygen. Okay, so that's what this is telling us. All right, so in the lungs, as hemoglobin travels through the lungs, there is lots of oxygen. Hemoglobin is 100% saturated. So it has picked up as much oxygen as it possibly can. And now it's going to begin to travel through tissue. When it travels through the tissue, resting tissue values of oxygen are 40 millimeters of mercury. So hemoglobin is going to travel through that tissue and it's going to give up some of its oxygen. How much oxygen is it going to give up? Well, by the time it leaves the tissue, it's going to be about 75% saturated, which means it has given up 25% of its oxygen. So tissue at rest needs about 25% of the oxygen that the hemoglobin is carrying. Contrast that to active tissue. Active tissue has a concentration of oxygen that is half of that of resting tissue, 20 millimeters of mercury. And at that concentration, hemoglobin saturation ends up being 25%, which means it has given 75% oxygen. So we have lowered the concentration of oxygen by half. We have tripled how much oxygen that tissue gets. And the reason why is because, again, you lose one molecule, the other three is going to follow. Also because under these conditions, there's going to be a high temperature, low pH, low oxygen, high CO2, which changes the shape of the hemoglobin so as to allow it to give up more oxygen. Okay, so what do you need to know from these? You should be able to read a saturation curve. Okay, so given a saturation curve, you should be able to interpret the saturation curve, hemoglobin saturation curve. And this is just talking about what we already talked about. This is saturation curves as we change temperature. So this right here is normal body temperature, 38 degrees centigrades. As the temperature increases, the saturation curve moves towards the right, so that at 40 millimeters of mercury, with a temperature of 43 degrees centigrade, which is a pretty high fever, now we have a saturation of about, 55%. So 45% has been given up. Whereas at normal temperature, we have 75% saturation, so 25% has been given up. Okay, so the high temperature is making the hemoglobin give up more oxygen. Again, you can see how the temperature is lower, the hemoglobin will retain more oxygen. This is the saturation curve for carbon dioxide, or pH, or both pH and carbon dioxide. So a pH of 7.4, which is normal, there's your saturation curve. You lower the pH, the curve moves to the right, meaning it's going to be more likely for the hemoglobin to give up the oxygen. And that's high pH, which the curve moves to the left. It will not give up as much oxygen. Okay. So that is okay. Yeah, the Bohr effect. That's something you will need to know. Essentially, it explains the relationship between pH and hemoglobin saturation, and essentially says that the lower the pH, the lower the hemoglobin saturation, meaning more oxygen has been given up. We've already talked about that. A low pH makes hemoglobin give up oxygen. So high hydrogen ion concentration, which is low pH, high CO2 is going to make the hemoglobin give up its oxygen. That's the Bohr effect. Hypoxia is a condition of low oxygen delivery that could be due to not enough red blood cells, abnormal hemoglobin or not enough hemoglobin, blood circulation, metabolic poisons, pulmonary disease, carbon monoxide. Okay, this next thing is important, transport of carbon dioxide. Definitely know these. Most of the carbon dioxide is going to be transported in plasma, not in hemoglobin, but not as carbon dioxide. Instead, it's going to be transported as bicarbonate ions. 20% will be transported bound to hemoglobin, 7 to 10% is transported as CO2, in plasma. I'll go into this in just a second. Okay, so this is what's going to happen to hemoglobin. I mean, not hemoglobin, sorry, to CO2. This is tissue. So CO2 goes into the blood, and about 7% of it is going to dissolve in plasma and begin to travel as plasma. About 20% of it is going to go into the red blood cell, bind to the hemoglobin, and just travel bound to hemoglobin. So this is 20%, this is 10%. 70%, however, is going to take a different route. It's going to go into the blood cell, and inside the blood cell, there is an enzyme called carbonic anhydrase. I'm going to just call it CA, which is going to combine CO2 and water and create carbonic acid. Carbonic acid is unstable. There we go. Sorry. Carbonic acid is unstable and it's going to dissociate. It's going to lose hydrogen and convert into bicarbonate ion. So the hydrogen leaves, and this is converted into bicarbonate ions. So there's the bicarbonate ion, which leaves the red blood cell, and now the CO2 is traveling in the plasma as a bicarbonate ion. That is a buffer. The hydrogen that is being produced will be picked up by the hemoglobin so that the red blood cell doesn't turn acidic. So this is what happens inside the red blood cells. Carbon dioxide and water combined, forming carbonic acid. Carbonic acid dissociates into bicarbonate ions and a hydrogen ion. The hydrogen ion binds to the hemoglobin, bicarbonate ion goes into the plasma. And most of the CO2 will travel as bicarbonate ions in the plasma. There's your buffer. Once we go into the alveoli, the whole process reverses and the CO2 is delivered to the alveoli. The Haldane effect essentially says is the relationship between CO2 and oxygen. So how much CO2 hemoglobin can transport depends on how much oxygen is hemoglobin carrying. So the less oxygen the hemoglobin is carrying, so that hemoglobin is not as saturated, the more CO2 it can carry, which makes sense. Okay, if there are more empty spaces in the car, then those empty spaces can be filled with CO2. Okay. Yeah, and at the tissue level, as more carbon dioxide enters the blood, the more acidic the blood becomes. The more acidic the blood becomes, the more oxygen leaves the hemoglobin, and that's the Bohr effect. The more oxygen leaves the hemoglobin, the more CO2 the hemoglobin can pick up. That's the Haldane effect. So the two go together and explains why at the tissue level, where you have low pH, high CO2, the tissue leaves the hemoglobin, gives up its oxygen and picks up the CO2. CO2 levels we maintain. Is that why sick? Oops, I never finished reading it. Give me a second. Okay, when you talk about how important it is that CO2 levels we maintain, is that why sick patients can have too much? Yes, and we're actually going to talk about that. That's exactly why. Yes, and there's actually twofold reason for that. There is such thing as having too much oxygen, because not only because of the CO2 levels, but also the drive to breathe does not come from oxygen. It comes from CO2. So if you remove CO2, the person stops breathing, because the drive to breathe is through the levels of CO2, not to the levels of oxygen. The levels of oxygen must fall incredibly low for it to become a stimulus to breathe. The stimulus to breathe comes from CO2. So CO2 is very, very important. And yes, you don't ever give a patient pure oxygen because the patient will stop breathing. You need, because essentially the principle is, why do I need to breathe if I already have oxygen? So there's nothing no stimulus to breathe. CO2 is the stimulus to breathe. So yeah, we're going to go into that. That's a good question. So when it comes to respiratory centers, there is a medullary respiratory center. Actually, there's two of those, the dorsal respiratory group and the ventral respiratory group. And there's also one in the pons, which controls the ventral respiratory group. Yeah, I'll mention the nerve here in just a second. Okay, so here is the ventral respiratory group, the dorsal respiratory group of the medulla. This is the pons respiratory group. And the muscles of respiration are being controlled by the dorsal respiratory group. The ventral respiratory group is going to influence the dorsal respiratory group and maintain it, its rhythm. So dorsal respiratory group is the one that integrates peripheral sensory input and modifies the rhythm generated by the VRG. Okay, so VRG is telling the DRG turn on, turn off, turn on, turn off. DRG is connected to the muscles, and so when it turns on, it contracts the muscles, then it turns off, relaxes the muscle, and there's the rhythm. However, the dorsal respiratory group, I got them backwards. This is ventral, this is dorsal. Sorry, this is the VRG, this is DRG. Let me clean this out. DRG, there we go. Okay, dorsal respiratory group is the one that is making the ventral one turn on and off. When the ventral one turns on, the muscles are contracted, then the ventral turns off, the muscles relax. The DRG is telling the VRG turn on, turn off, turn on, turn off. The DRG, and this is when I stopped and said, wait a minute, there's something wrong. It's because the one that is turning on and off, it should be the one that is receiving information from receptors. So the DRG is receiving information from receptors, and the information is about oxygen levels, actually I should say CO2 levels, pH levels, those are the two main ones, and then yeah, oxygen levels, if oxygen falls low enough to become important. Normally, these two are the ones that is receiving, and actually that's brain. Brain doesn't even receive information about O2, okay? Receives information about CO2 and pH, hydrogen ions. And depending on the information that is getting, as far as the levels of CO2 and levels of pH, it will increase or decrease the respiratory rate. Okay. The pontine is going to modify both DRG and DRG. So it modifies the medullary respiratory centers. Okay, so the depth of respiration is how actively the respiratory center is stimulated. The rate is how long is the center active. The receptors that are going to modify respiration are going to be sensitive to CO2, pH, and oxygen. However, the central chemoreceptors, the ones in the brain, especially the medulla, and levels of CSF, respond only to CO2 and pH. So peripheral receptors are the ones in the aortic bodies and carotid bodies, and they're going to monitor CO2, oxygen, and pH, with the caveat that CO2 is the main one, pH you would say maybe second one, last one is, as far as in importance, is oxygen. So what if we have high CO2? High CO2 is accompanied by a low pH. Peripheral receptors are going to detect the high CO2 and it's going to give that information to the medullary center. Central chemoreceptors are, again, going to detect the high CO2, the low pH, and give that information to the medulla. The medulla, in turn, is going to increase the rate of respiration so as to increase ventilation and get rid of CO2. So lower the abnormal CO2, the levels of CO2. You lower the levels of CO2, you increase pH. An opposite situation will be hyperventilation. When we hyperventilate, we lose CO2. And when we lose CO2, that's going to increase the pH, and that is going to decrease respiration in order for us to keep CO2. Typically, if it becomes very dramatic, there will be vasoconstriction of blood vessels in the brain, which will eventually cause loss of consciousness, so that we will stop breathing and accumulate CO2. So we need to stop breathing in order to keep the CO2, at least for a while, until things go back to normal. Okay, so factors that increase depth and rate of breathing will be too much CO2, low pH. And then we talked about increased temperature. We'll also do it. All right. We talked about the peripheral chemoreceptors can actually also detect oxygen. However, you need a substantial drop in oxygen for it to be a stimulus to breathe. You need to go to as low as 60 millimeters of mercury. Okay. Yeah, a decreased pH may be due to CO2 retention, as happens with emphysema, exercise, ketone bodies, which happens with diabetes patients, the metabolic acids. So a diabetic patient on a coma, on a diabetic coma, or on acidosis is going to have an increased respiratory rate. Okay. Again, rise in CO2 levels is the most powerful respiratory stimulus. Oxygen has to fall below 60 millimeters of mercury for it to become a drive, a stimulus to breathe. Okay. Other things that can control breathing will be emotions, the emotional brain, the hypothalamus, a rise in temperature, the cortex, voluntary control, the cerebral cortex. All right, let me just skip to, okay, before I skip to the last PowerPoint, let me just go over this real quick. Yeah, the stretch receptors in the lungs. The minute you stretch the lungs, there is a signal going to the brain to breathe out, so as to deflate the lungs. So inflation of the lungs triggers a reflex to deflate the lungs. This is called the Herrn-Brauer reflex, and this is more a prevention of overstretching than anything else. However, in babies, in infants, is a very important reflex. It's what regulates the basic breathing rhythm of an infant, is the Herrn-Brauer reflex. Okay, this PowerPoint here is incredibly important because it summarizes a lot of information we've been talking about. All right, so positive means we're going to increase breathing. Negative means we're going to decrease the rate of breathing. So exercise increases the rate of breathing. peripheral chemoreceptors. So the peripheral receptors in the aortic bodies and carotid bodies are going to respond to high CO2, high hydrogen ion concentration, which means low pH, and low oxygen by increasing the breathing rate. The chemoreceptors in the brain only respond to CO2 and hydrogen ion concentration. High CO2, low pH, again, increases respiratory rate. Emotional brain, hypothalamus, can either stimulate or inhibit respiratory rate. Voluntary control from the brain, from the cerebral cortex. Again, we can increase the respiratory rate or decrease it at will. The stress receptors, Henry-Bauer reflex, decreases respiration. Irritants will decrease respiration. So basically, it's the summary of what we've been talking about. Okay. Acclimatization to high altitudes is going to do several things. Peripheral chemoreceptors will become more responsive to CO2. If oxygen declines enough, they will also become responsible to oxygen. Minute ventilation is going to increase and will stabilize within a few days in order to, so the minute ventilation becomes higher than at sea level. And the declining levels of oxygen are going to stimulate the kidneys into producing EPO. So we're going to end up with more red blood cells within a matter of weeks. So within a matter of weeks, we're going to have increased red blood cells, increased minute ventilation, and at least temporarily, we're going to have an increased respiratory rate. Okay, I think that's it actually. Oh, and normal conditions, COPD, talked about that, is a obstructive disease. Chronic bronchitis is a COPD, emphysema is a COPD. And this is just talking about tobacco or pollution is going to inflame the bronchus continuously, creating chronic inflammation. Other toxins can break down the gas tissue in the lungs, and that creates emphysema. These will all end up with obstruction of the conductive zone, dyspnea, which means difficulty breathing. And now we're going to have abnormal ventilation-perfusion ratio, which will lead to hypoxia, low oxygen, and hypoventilation. Okay, we talked about, we know what asthma is. Okay. All right. Questions? Okay, guys. So finish this chapter. So